podcast was, you had talked about Optum kind of transitioning from a batch mindset to maybe real-time point of care clinical
Right?
decision support.
Yeah.
Is there, I guess in one case, maybe you could sort of elaborate a little bit more on this real-time aspect. And do you think AI needs to be real-time to really be AI? That's a little bit of a side question, but yeah, I'd be curious to see what you think.
That's really important. So, right now in healthcare, in the United States, we're dominated by this thing called fee for services. And fee for services is every time you go and have a procedure done, maybe an eye exam, a health checkup procedure, every time you go to a hospital, they code everything that happens and they get reimbursed for the number of procedures they do. And the more procedures they do, the more they get reimbursed. So there's no incentive systems in place to limit the number of procedures that are maybe borderline. Maybe they're not really necessarily. If they're clearly not necessary, that's fraud, but there's a huge amount of edge cases. My wife had a spot of indigestion a while ago, and she went in and they did $13,000 of highly invasive tests just to make sure it wasn't heart related problem.
Wow.
And if they really would have looked at the data and her Fitbit data and all those, so she had a very, very healthy heart.
Mm.
There was no real reason to do $13,000 to test. And that's a good example of how the old way is doing. Now, what we're trying to do is move to this thing vertically integrated, where Optum doesn't just do the claims for companies. We actually own the clinics. We pay the doctors and the nurses as our staff, they're full time employees, just like Mayo Clinic has full time doctors, and that we also provide the insurance, which means that we are highly incentive to give high quality care and yet also minimize unnecessary procedures.
Mm.
And
Gotcha.
that the studies in general, those are called ACOs, accountable care organizations. The general studies at ACOs are about 30% less than fee for services. And so what we're trying to do is transition that. And that means we have to buy clinics. But what's important about that is when a physician or a physician assistant or nurse makes a judgment about what tests are necessary, what drugs are required, they'd like to be able to use data. And the point is, you can't run a batch job overnight and say, look, according to your symptoms and your clinical history and your entire genome and all your background, we're going to come up with the right drug for you tomorrow, right? That just doesn't fly, right? It's when the people are using that electronic medical record system and they say, well, we're going to give you a prescription for an antibiotic. And what they might do is they might have a deal with the local drug company and they'll give you a very expensive drug. Or what if we could tap into the entire equally effective settings and give you the least expensive drug? The point is we have to do that. We have about 100 milliseconds to make sure there's no lag in that drop-down list. 100
Wow.
milliseconds. And that's what we call real-time. Real-time clinical decision support. Now, we're not trying to take over the job of a physician or nurse. What we're doing is give them a ranked list of options and the pricing associated with that to help them make better decisions and then also explain it, right? So we can't just make a recommendation. Our AI has to explain why. And the reason why is that we use real world evidence. Real world evidence is a term that we're using over and over to say, gee, we have 200 million people in our database, and we've extracted the 20,000 that are most similar to you, and we've looked at their profiles of which drugs are most effective, and here are the ones that we are recommending. And then we let them choose and make those decisions.